going to talk today about aging skin. It's a very wide topic. I have no disclosures. And the outline of my talk, I will start first talking about the skin as an organ. And then after we will move to describing what is the aging skin. We will see some histology studies and molecular mechanisms related to the developing aging skin. And then I will present some resurfacing techniques that we are using nowadays. And then after, I will explain some surgical anatomy related to the aging phase. And then we are going to talk about cosmetic surgery. The word cosmesis comes from the word cosmos. It's a Latinized form of the Greek cosmos. And cosmos means order, good order. And it's an orderly arrangement. We use cosmos with a little bit of different meaning. We mean with cosmos as the universe, as the world. And it's a kind of new word for us. It was not popular until the 19th century in the English. And it was taken from the German. It was taken from Dr. Humboldt. Humboldt is a very well-known scientist, traveler, explorer, biologist. That he described beautifully biology studies, and we took to the English his word cosmos. And then thinking about the skin, when I was preparing this talk, I started to think about the soil. The skin has some different layers that we call horizons, and the soil has also layers with a profile. There is a skin profile and there is a soil profile. And then scientists, they know that when they have to study a soil, they have to study the layers, the life, because the layers of the soil reflects the life of the soil. And then there is a well-known saying, if you know soil, you know life. And these are the different layers that we can see in the soil. It goes from the bottom to the top. In the bottom, there is no life, inorganic material. And it goes from bedrock to weathered rock fragments to subsoil, topsoil, more water, and humus. Humus is what we understand with life, the organic life. Is where there is carbon, oxygen, nitrogen, and this combination of atoms and molecules makes life. The skin is reversed. The living cells are at the bottom and the dead cells are at the top. And why is that? Because the skin is a protective organism. It's a protective organ. And the main function of the skin is protection from the environment. And also the skin is an organ to defend us against infection and injury. And then the structural anatomy of the skin is very important to prevent to have infections and injury. Also, it's a great organ to regulate the temperature. When you exercise in the dermis, the vessels, they vasodilate. And then it's a way to lose water and heat. And then it's a way to clean the skin too. It's an optimal way to clean the skin, the exercise. Also, the skin is related to the vitamin production, especially vitamin D, and it's a store of vitamins organs too. And it's a very important sensory organ, especially in humans. Humans are not that good with the eyes and not that good with the ears when you compare with animals, but humans are great with touch. It's like we have expression of touch me, touch my heart, because touching is very important because it's related to the limbic system, to the emotions, and to the memory. And then the skin as the biggest organ of the body combined with this highly specialized sensory function, it makes a very important organ for human life relationships. And then we have three main layers in the skin. We have the epidermis, that is epi, it comes from the Latin, it means upon, over the dermis. And then we have the dermis, that is the core, is the real skin with all this integumentary system. And we have the hypodermis or hypodermis, that is under the dermis. Hypo means under. And then the epidermis, the main function is mechanical and antimicrobial barrier, and consists of several layers that we will describe. The dermis is dense in connective tissue because it's supportive for the epidermis. And the dermis has blood vessels, hair follicles, and sweat glands. And it's a very important organ for the immunity. It has a lot of immune cells. Then we have the hypodermis, that is more loose, connective, and fatty tissue. And it's important in the body temperature control. Then talking about skin health is a big issue in research. And there are three main factors. The first one is the environment, is what is around us. And there is a lot of studies describing the effect of ultraviolet radiation on the skin. And nowadays, with the developing countries, we have a lot of studies too talking about air pollution and pesticides and the effects on human health through the skin. Then a key factor for the skin health is the diet. And poor diet has been linked in many studies to premature aging, and especially to vulnerability to cancers, especially to melanoma. And there are many studies relating advanced melanoma staging with, for example, deficient vitamin D in the body. And then in the skin also is a place where bacteria, viruses, and fungi live. And this microcosmos or microbiota contribute to the health too. And then some of these bacteria and viruses and fungi exacerbate conditions or make diseases, and other ones offer protection to the humans. And then in the epidermis, we have different layers. The outermost layer is the stratum corneum, that is made of dead, flattened cells filled with keratin. There is no life in the corneum. And there is a microbiota, that all this combination of dead cells with the bacteria and fungi makes a wonderful environment to prevent overgrowth of bacteria and virus, because it's a very harsh environment. It's dry, it's nutrient poor, and it's very acidic. The pH is around 4 to 5. And then makes hard for the bacteria and the virus to live on the skin. But there is some bacteria that they have found a way to survive. And then there is a mixture of bacteria and fungi and viruses. For example, on the face, there are studies that they show that there are Staphylococcus epidermidis, and that makes enzymes that prevents the growth of another bacteria. For example, Staphylococcus aureus or MRSA. And in the face, talking about fungi, we have the Malassezia furfur, that is very prevalent in oily areas, forehead areas, for example, perioral and periocular areas, that also contributes to health in humans. And we have viruses also too in the skin. Then under the corneum, we have the stratum lucid, that is very prominent in the palms of the hands and the soles of the feet. And they are also dead cells, is another no life layer, and it's lipid rich. And these lipids in the stratum lucid makes the skin waterproof. It's like the skin has to keep well hydrated, and the cells below this stratum, they need a lot of water. And then nature has created a layer of lipid to prevent the water to be lost. And there is also a product, it's called eladen, that is a transformation of the molecule keratohyalin that gives structure to the stratum lucid. Then we have the stratum granulosum, that is made by mature keratinocytes. Keratinocyte is the main cell in the epidermis. And the cells here are alive, but they are dying, and they are on the move. They are moving up. And these cells, these keratinocytes, are filled with keratohyalin granules. We have the stratum spinosum. It looks like a spindle-like cell layer in the microscope. It's an artifact, and that's why it's called a spinosum. And they are keratinocytes migrating up. They are full of water. They look very healthy with a big cytoplasm. And they have these spike-like processes. And they give this pavement road configuration to the skin. Then we have the stratum basale or germinatum, and they are the cells that they are proliferating. They are in mitosis. They are constantly proliferating cells. It's a great organ for study regeneration and reepithelialization. And this is constantly proliferating cells. And also in the stratum basale, there are melanocytes, and we will talk about them too. And then the epidermis is a constantly moving organ. When we see a histology picture, it's a snapshot of cells that they are moving up. And it's a slow moving, it takes time. And then one cell from the basal layer to reach the corneum, it takes 1 month, around 1 month. That's why it takes time to heal deep wounds. Then this is a histology picture of a pathology book that shows the configuration of the epidermis. And just to remember that this is a constant renewal organ. There is migration and maturation involved. And these are bold questions. They ask where are the hemidesmosomes. The hemidesmosomes are in the basal layer, and they are attached to the basilar membrane. And they are in these proliferating cells. And the desmosomes, they are in the stratum spinosum. They are made of keratin, hemidesmosomes and desmosomes. And there are many groups studying the regenerative potential of the skin, and many groups looking for better ways of healing burns and deep wounds. Then in the epidermis, there are another cells other than the keratinocytes that are very important. We are going to start with the melanocytes. Melanocytes are situated in the basal layer of the skin, and they have these prolongations around the keratinocytes. And talking about diseases, we have the albinism. It's a hereditary condition. They have normal number of melanocytes. The problem is that they don't have an enzyme, it's the tyrosinase. And then they cannot make melanin from tyrosine. And then this lack of enzyme makes the people to be white, absolutely white. And we have the vitiligo, that is another disease of melanocytes. This is an immunitary problem. They have antibodies and white cells that they attack the melanocytes in some areas of the skin, especially perioral areas and acral areas. And they have these distinct white patches on the body. Then we have the freckles, that they are common in aging skin, is when the melanin starts to aggregate in patches. There is no diffuse tanning in all people. There is just aggregated patches of melanin that make freckles. No, not all people. Some people is young with very light skin, they start to have freckles. And then another pathology of melanocytes is very important for us is the seborrheic keratosis, the liver spots. That we have to distinguish this one from melanoma and from actinic keratosis. And they are benign growths of melanocytes. And they are very common, very frequent. The melanocytes, they come from the neural crest cells. And then this is a picture of the neuralization. And then we see that the neurons, they come from the ectoderm, and this green are the neural crest cells. And then this is a specialization of the ectoderm. It's called neural plate border. It makes the neural fold. And then at the top of the neural tube, they are migrating cells. Neural crests are migrating cells. And they migrate through all the body. They give rise to the melanocytes. They are very important for the ENT areas. They give rise to the craniofacial cartilage and bone, and they give rise to the parafollicular cells of the thyroid that secrete calcitonin, the chromatin cells of the adrenal medulla that secretes catecholamines, the smooth muscle, and the cranial nerves, and the glia, and also contribute to the thymus and the bones of the middle ear and the jaw, and the odontoblast of the tooth primordia. Then we have three skin pigments in the skin. We have the melanin, the carotene, and the hemoglobin. In this picture, we see on the left, a patient or human with dark skin, and on the right, a human with light skin. And we see that the main difference, or the only difference, is the distribution of the melanosomes. This is a board question too. We have the same number of melanocytes. It's like the left and the right has the same number of melanocytes. It's the amount of melanin production and the distribution that makes the difference. The melanin is secreted whenever the sun reaches the melanocytes. And the dark skinned people, they have more production of melanin and wider distribution of the melanin. It's the only difference. And the light people, they are used to live in cloudy places, and then the melanocytes are not so responsive to the sun. Then another skin pigment is the carotene that is in the diet. And it's very well studied, the effect of the carotene on the skin, because it's great, because it's an antioxidant. It means that neutralizes free radicals. The free radicals, they are all requesting electrons for molecules, and they are very dangerous. For example, you have free radical steal one electron from the DNA. It changes the conformation of the DNA, and it makes mutations. And then the carotene is something to neutralize free radicals, because donate electrons to the free radicals. And also beta carotene is a precursor of the vitamin A that is very important too for the health of the skin. And the highest concentration of the carotene is in the stratum cornea. Corneum. It's a pigment, and then protects from the sun and probably from air pollutants too. And why it goes to the stratum corneum? Because it's fat soluble. Whenever it's a lipophilic molecule, it goes easily through the plasma membranes and distributes easily through the skin. And also accumulates in the sebaceous and sweat glands, the carotenes, and from there to the hair shaft, it goes directly to the stratum corneum. We have a disease, it's called carotenemia. That is when we have an excess of carotenes in the diet, or when also when we have a lack of the enzyme that produces the vitamin A. And carotenemia doesn't give an orange skin, it gives a yellow skin. And then we have here the chemistry of the autumn leaf colors. We have the left is the summer and the spring, and with the high temperatures and with the sun rays, the leaves, they produce chlorophyll. That is important for getting energy for the plants. Then with the autumn, with the fall, the temperature starts to drop down. There is less strong sun rays. And then the chlorophyll doesn't develop so well, the plant doesn't make chlorophyll so well, and they start to break down and diminish the color of the leaves. And then we start to see the other pigments of the leaves, that they were there already, but we didn't see them because the chlorophyll took over them. But once the chlorophyll is not produced enough, we start to see the carotenes, the carotenoids and the flavonoids. And these are the colors of the carotenoids and flavonoids. And then these pigments are a very good reflecting light. It's like they reflect from the blue and green light of the sun. They make red and yellow light. And then this is what we see. We see the red and yellow light that reflects the blue and green light. And they degrade at the same rate that the chlorophyll. The only thing that they remain maybe more time. Then another pigment is the hemoglobin, and we see this when the patient becomes blue. It's called cyanosis, when they have more than 5 grams per DL, hemoglobin in the blood. Also, another pigments related to pathology is the bilirubin, like it's a yellow skin, what is called jaundice, and it's related to liver and gallbladder disease, the direct bilirubin. And these are another pigments in the skin. One is produced by the pituitary gland. It's called melanocyte stimulating hormone and makes a darkening of the skin. Another one is the suprarenal insufficiency, that is called Addison disease, that makes the pituitary gland to secrete more ACTH and gives a deep bronze color because it stimulates the melanocytes too. Then another cells in the epidermis are the Merkel cells that are mechanoreceptors. They are transducer from a mechanical stimulus pressure on the skin. They transduce to an electrical signal to the sensory neuron that goes to the brain. And we have also Langerhans cells that are very related to the immunity, and they are antigen presenting cells situated usually in the spinose layer of the epidermis. Then under the epidermis, we have the dermis. That the main functions of the dermis are support and elasticity. Support is given by collagen, the protein collagen, and elasticity given by the protein elastin. Also, the dermis give us an important protection from pathogenic microbes and toxic substances. And we have a lot of immunitary cells. For example, we have mast cells that identify pathogenic species and releases chemical signals to attract other immune cells. And they are very related to inflammation, especially with chronic sun exposure and pollutants. Mast cells, they become overreactive. And we have inflammation on the skin. We have redness on the skin. We have T cells too. That is a white blood cells that remember the microbes that we have encountered previously. We have dendritic cells that are antigen presenting cells to other immune cells, and we have the macrophages that clear the cellular debris that are very important. And these cells, some of them, they release enzymes, and if these cells, they are overactive, these enzymes are dangerous for the structure of the dermis because they degrade the collagen and the elastin. Then we have here the histology section of the structure of the dermis. We see a very important element that is the epidermal-dermal union. And we see that there are projections in the epidermis and in the dermis. And why we have these projections? Well, I think the main benefit is that the more projections that we have, the more number of proliferating keratinocytes that we have. And then the higher healing potential of the skin. This is related to a skin that is young, to have a lot of projections. And the projections, they have names. They call them retipex if they are epidermal, and they call it papillae if they are dermal. And they have small vessels, microvasculature that are very important for the health of the skin. Then the dermis is divided in layers too. There are only two layers in the dermis. We have the papillary layer, that is the outer layer. We have loose connective tissue because we have small blood vessels and nerve endings. It's like the survival of these small blood vessels are key for the health of the skin. And we have also, inferior to the papillary, we have the reticular layer that is dense, is with a highly protein material. And we have irregular connective tissue. And then under the dermis, we have the subcutaneous layer that is the hypodermis, that is deep to the skin and contain the fat and the fibrous tissue. The main cell of the dermis is the fibroblast. That is the most robust cell that you can find in general. When you do in vitro studies, cultures, it's great to work with fibroblasts because they survive almost all the conditions and they overtake another cells. And the fibroblasts, they are specialized cells too in producing collagen. Collagen is a vital protein for the structural support of the skin. And there are some studies that they claim that it binds water. And the elastin is very important for the aging skin because it gives elasticity to the skin. Aging means loss of elasticity and increase in laxity. And elastin is a more fragile protein in the dermis that gives the elasticity. And then we have the ground substance of the dermis, that is everything that is not all these elements, that they are glucosaminoglicanes and proteoglycanes. And one of the most important are the hyaluronic acid. Then the collagen is the main protein of the skin and is the most abundant protein in the organism. We have 4 different types of collagen that they like to ask in the boards too. The type 1 is the more frequent and is maybe the most important. It's in the skin, in the bone, and in the tendons. We have one disease that is called osteogenesis imperfecta, when they don't produce enough type 1 collagen. We have the type 2 that is present in the cartilages. And we have the type 3 that is called reticulin. It's the granulation tissue, it's the healing tissue. The deficiency of this protein makes a disease that is called the Ehlers-Danlos syndrome. That is very important to know. You work in cosmesis. And we have also the type 4 collagen that is present in the basement membranes in epitheliums. Then we have this disease that is called the Alport syndrome that has consequences in the hearing because there is an epithelium in the cochlea and in the kidney because there is another epithelium to filter the urine. And we have here a picture of the collagen with a fibril, microfibers. And we see that the collagen is a very complicated structure with a 3D conformation. The DNA is a 2D, it's a double helix. Not 2D, it's double helix. The collagen is a triple helix. And then the osteogenesis imperfecta, and the symptoms that we have is the lack of type 1. We have blue sclera. It's an autosomal dominant disease with different expression and penetrance. These are the genes. Col comes from collagen involved in, these are the mutated genes. And we have bone fractures, even in childs. They can be confused with child abuse. These patients, they break bones very easily. They have hearing loss. They have opalescent teeth, short stature. They are very short. And they have joint laxity. You can see the coronoid in the eyes. That's why they are blue. The lack of collagen makes the coronoid visible. And the lack of type 3 reticulin makes the Ehlers-Danlos syndrome. It's called cutis hyperelastica. And in cosmesis, it's very important to know this because it's not advisable to do cosmetic surgeries to these patients because they don't heal well. And then they can be dominant or recessive with different expressions. And they have fragile, hyperextensible skin with easy bruising. It means that they don't heal well. They have hypermobile joints with brain aneurysms, mitral valve insufficiency, and a predisposition to hemorrhages with a dark skin pigmentation. In the figure we see on the left, what is the normal collagen structure and arrangement in the dermis. And this is the skin laxity. And this is an Ehlers-Danlos microscopic electronic study that we see this agglomeration or aggregation of collagen fibers. This is typical in the Ehlers-Danlos, and this is typical also in aging skin. They lose the structure and the skin becomes more elastic. Sorry, it has more laxity and less elastic. And another disease is the Alport syndrome that I talked already. It has the lenticonus, sensory neural hearing loss, and microhematuria. And this slide shows how complicated is the collagen synthesis. It's something that we have studied in the medical school, like an example to study the synthesis of a protein. And we see all the post-translational steps that requires to make the 3D configuration of a protein. And then we remember that the mRNA is translated to a procollagen in the RAF endoplasmic reticulum. And then there is a hydroxylation of lysine and proline amino acid and requires the vitamin C as a cofactor. That's why it's important, the vitamin C It's important for the synthesis of collagen and the health of the skin in general. Then there is a glycosylation of the one amino acid, and this is the step that it doesn't work in the osteogenesis imperfecta, the glycosylation. Then there is exocytosis from the endoplasmic reticulum. It goes to the Golgi apparatus with some changes in configuration, and then it goes outside from the fibroblast. There is a proteolytic processing with cleavage, and it's cleaving to tropocollagen. It makes the collagen insoluble. And this is the step that doesn't work in the Ehlers-Danlos syndrome. Then afterwards, the collagen has a cross-linking by an enzyme that needs copper. The enzyme name is called lysyl oxidase, and makes the collagen fibers. And this cross-linking increases with the aging of the skin and decreases the elasticity of the skin. Another protein that is very important in the dermis is the elastin. The elastin, in this picture, we see that it has different configuration than the collagen. It's much thinner, doesn't have this 3D configuration of the collagen. And the elastin is important because it resumes the shape of the skin after stretching or contracting, or when the skin is poked or pinched. This is a sign of aging skin when it doesn't resume the shape after the stretching. And it's very important in arteries because it's important for the pressure wave propagation. It's also involved in the lungs, in the alveoli, in the elastic ligaments, and in the bladder. There is no triple helix formation in the elastin, no hydroxylation, and no glycosylation. These are the differences with the collagen. And it's more fragile than the collagen. The diseases that we have when the elastin doesn't work, one of them is the cutis laxa, dermatochalasia. That is very important for cosmetic surgery too. Is there are patients, it's a genetic disease that they have a decreased size and number of the elastin, of the elastic fibers in the dermis. And the main symptom is the skin laxity. We see in the eyes, in the periocular area is the most dramatic changes. We see the herniation of the orbital fat pads. We don't see the crease between the eyelid and the eyebrow. And it's because the orbital septum has decrease of elasticity and has more laxity. And then the orbital fat pads prolapse. These patients, they have entropion and they can have tensional headaches. These patients, they are great candidates for cosmetic surgeries because the collagen is good. There is no problems with the collagen. And they don't have good wound healing difficulties. There is no vascular fragility, and they are very good candidates for surgery. Another diseases related to the elastin is the Marfan's syndrome. That is an autosomal dominant disease with different levels of expression. There are a lot of people with Marfanoid habitus or signs. It's a defect in the fibrillin. The fibrillin is an amino acid important in the formation of elastin. And these people are tall, are thin, and they have hyperflexible joints. Big problems is the aortic aneurysm. They have ectopia lentis because the crystalline is not holding position enough by the ligaments, and they have this pectus excavatum. Another disease related to elastin is the alpha-1 antitrypsin deficiency that is related to emphysema and cirrhosis because this enzyme degrades the elastase. And then if we don't have this enzyme, there is a lot of elastase, and the elastase degrades the elastin. And the elastin is very well known, associated to the development of wrinkles of aging. This is a histology section of shows how important is the elastin in the aging skin, because we see this landmark of aging skin that is called solar elastosis. Is this basophilic degeneration of the elastin fibers that takes over almost the entire dermis. And this is made by prolonged and excessive sun exposure, photoaging. We see another characteristic of aging skin is the flattening of the epidermal and dermal layer. And then I'm going to talk about skin aging now. And first question is why? Well, a good answer is because we have to, but there are many studies trying to show what factors are the most important in the theology of aging. In general, for the skin, lifestyle is predominant in the importance, combined with their heredity, but lifestyle is very important for the skin aging. And many studies show that the greatest influence for skin aging are related to substance and alcohol abuse, sun exposure, and emotional distress. We have intrinsic aging, and many factors of this we cannot control, and we have extrinsic aging, and that most of them we can control. And then thinking about the solar spectrum, we have in this picture the different wavelengths, names of the solar spectrum, and we see that the various wavelengths penetrate into the skin at different levels. Then the longer the wavelength, the deeper the penetration. That's why the shorter wavelengths of the ultraviolet B, it goes only to the epidermis, and it can damage the melanocytes and the basal cells. And the infrared and visible light, that is a longer wavelength, it goes deeper, it goes to the dermis and hypodermis. There are different layers. The ultraviolet C is the one that does not reach the skin because it's filtered by the ozone layer. But most of the other solar spectrum reaches the skin. The ultraviolet V is the most energetic with a shorter wavelength and penetrates the epidermis into the basal layer. The ultraviolet A, it was thought before that didn't have any effect on the skin. That's why it was very widely used, the UVA lamps, to give some tan color to the light skinned people. But now we know that they are harmful, that they penetrate deeper than to the skin, and they reach the dermis. They can injure the fibroblast, and when you injure the fibroblast, the next step is the keratinocytes. The keratinocytes, they need healthy fibroblasts to be alive. Then we have the visible light, that is the most of the total solar spectrum, is the 50%, and the infrared radiation, that is the remaining 45% of the solar spectrum. And these are the mechanism of skin injury. The UVA, they do DNA oxidation in the dermis, and visible light and infrared, they create heat, and the heat makes oxidative damage to the DNA and other molecules. Then all the spectrum makes reactive oxygen species and nitrogen species that they are free radicals. And all of these, they are related to photoaging. This is a complicated slide about the molecular mechanism of skin aging. We just have to know that they are involved inflammatory cell signals pathways. There are many cytokines involved, these interleukins that are the bad ones. And there is a constant in the skin self-repairing reaction of cells that they can harm another cells. And then there is known that the ultraviolet B radiation makes a direct damage to the DNA. It makes mutations and modulates the activity of cytokines. And the ultraviolet A radiation initiates the formation of reactive oxygen species and activates enzymes like metalloproteinases. Then these enzymes in the dermis, they degrade the collagen and the elastin. Then the more sun exposure that you have, if it's uncontrolled, is more aging of skin in general, especially for light skinned people. This is a mechanism of sun damage to the DNA that is very well studied and very well known. And it's called the thymidine dimer formation. Then we have an incoming ultraviolet photon, and it changes the configuration, the double helix configuration of the DNA. And this thymidine dimer is a photoproduct of the DNA induced by this ultraviolet radiation. And we see here in yellow two thymidine, pyrimidine bases that they combine together with a covalent link and destroy the structure of the DNA. And this is the the domino effect. This is the first step of many effects that lead to mutation, and eventually these cells, they become cancerous or they die, increasing the inflammation of the skin. Then this is just to show that this is a very small change in the structure of the DNA. It's a very subtle change. It's just a covalent link between two bases. And this small change, this link in all the structure of the DNA, has a very profound effect in the behavior of the cell. This is the link. It's called cyclobutane pyrimidine dimer, and it's related to the formation of melanomas and skin cancer, because it interferes with the base pairing during the DNA replication, leading to mutations. There are repair mechanisms of this DNA damage that they are very well studied, and they continue to be studied. And in plants, they have a great mechanism to repair the pyrimidine dimer formation. This is plants, and these are prokaryotes and some eukaryotes. This is not in humans. And then plants absorb light wavelength and enable a photochemical reaction to occur, which results in the elimination of the pyrimidine dimer. This is great, but it works in plants. In humans, it's much more complicated story to repair a dimer in the DNA. We have a very complicated mechanism with a lot of transcription factors, proteins, promoters, enhancers that regulates the healing of the DNA once it has a dimer. And this mechanism is orchestrated by three different enzymes: the endonuclease, that is an enzyme that releases the damaged bases, cuts the dimers. Then we have the DNA polymerase that makes new DNA, and the DNA ligase that fill and reseal the gap. And it takes time and effort for the cell to do all this process. And in a young cell, is able to do it, but in an old cell, it has more difficulties to repair the dimers. And what happens when this mechanism doesn't work at all, when we don't have any nucleotide excision repair in the body? Then we have this disease that is called xeroderma pigmentosum. That is a very dramatic disease. It's autosomal recessive. We see a lady here from Guatemala. That is Guatemala, probably she was exposed to sun and covered with no sun cream protection. And we have a man that is very healthy because it's recessive, it's genetic, and it's decrease of this nucleotide repair mechanism. These patients, they have severe sunburns after only a few minutes in the sun. They have a lot of freckling in sun exposed areas. They have very dry skin and skin pigmentations. These are aging skin when they are children. They have high risk of skin cancer. And about half of them, they have skin cancer by the age of 10 without preventive efforts, and they have cataracts too. In the etiology of aging, another factor that is being very well studied is the pollutants and pesticides. We have here a picture of a city of a developed country, what we call developed country. And some people will say this is an example of uncontrolled production combined with uncontrolled consumption. And then the skin is a protective organ, but it's porous enough to. It has some holes where the pollutants and chemicals, they can pass through the skin. And then when they pass through the skin, they have a wide effect in the human health. There are studies that they show that high concentration of air pollutants are linked to asthma, development of asthma, infertility, and some types of cancer. There are some studies showing relation to breast cancer. This is a very well-known pollutant that is called polycyclic aromatic hydrocarbons. That is what the cars release, especially the old cars. And it's released also when we have in California this wildfire smoke. The danger of these carbons is that they are lipophilic. When they are lipophilic, it means that they are dangerous because they go through membranes and they go through the skin. They go through the fat-filled spaces of the skin, so the stratum lucidum, and then they enter the blood, and they have widespread effects. The skin is 50% of the weight of your body, and is highly exposed to these pollutants. is well known in scientists that they say that if a chemical is toxic through the ingestion or through the inhalation, it's going to be toxic too through the skin absorption. And there are some Chinese studies with immortalized human skin cells that they expose them to the air particulate matter, what we call soot, and this exposure leads to the formation of free radicals. That free radicals means DNA mutations and cell death and cancer. And there are good news too about the skin and the keratinocytes. We have here at the top on the right, we have the detoxifying cells, that is the hepatocyte in the liver, that is the highly specialized cells to remove toxin. And the hepatocyte has influx proteins and efflux proteins with a metabolism inside cytochrome P450 proteins. The keratinocyte, similarly to the hepatocyte, is a detoxifying cell too. It has been studied, and they are studying ways to promote this metabolized mechanism. And then we have these influx proteins too. We have the cytochrome P450 proteins or enzymes, and we have the efflux proteins that they have been characterized in the keratinocytes. And there is a new name now, it's called xenobiotic. It's when a chemical substance is found within an organism, for example, pollutants in the skin, that is not naturally produced or expected to be present within the organism. It's a big area of research too. And then these are the responses of the skin to inflammation or injury. They are, first to know is that they are very limited responses. And then to have a diagnosis, usually you have to combine histology with how it looks the patient in the skin. It's very hard for pathologists to have diagnosis only with the histology. We have here, because it's very limited repertoire of responses to the injury in the skin. We have here on the top right, we have the normal skin with different layers with normal keratin. We have processes in the skin and they have hyperkeratosis, for example, in ichthyosis vulgaris, in psoriasis. And this hyperkeratosis is related to hypergranulosis and acanthosis. Acanthosis means that the epidermis is bigger, is more thick. And this is typical in psoriasis. We have also parakeratosis, is when the stratum corneum, they start to have some nuclei of cells because there is a loss of appropriate differentiation of the keratinocytes. There is no granular layer in this parakeratosis, and start to be this process called dysplasia of the basal layers of the epidermis, and this is very typical of the age in the skin. Then the next step after the dysplasia is the actinic keratosis that is very common on the face, and we should know very well. We should know them and we should follow them. They are skin lesions that they have hyperkeratosis and parakeratosis. They look like scaly, discrete, flat, or raised. They can be verrucous or keratotic plaques or papules, and they can be pigmented or erythematous or color. They occur very commonly on the face and in the ears, and there is a lot of ways to treat them. And the most important thing is that they are pre-malignant. There are a lot of studies trying to identify what is the percentage of becoming malignant, and they are resulting from chronic sun exposure. These are what is known about the progress to squamous cell carcinoma. Is the annual rate of it's low, 0.24% for each lesion. By some authors, they claim that over a 10-year period, a typical patient has a 10% chance of at least one actinic keratosis transformed into a squamous cell carcinoma. And this is something that we should follow. These patients, they should be followed. The next step is the basal cell carcinoma. These are two typical pictures of the basal cell carcinoma. It has this, it's the most common skin cancer. It has this configuration, nodular, pearly opalescence is very characteristic. And also very characteristic is the prominent telangiectasia that they have. they sometimes they present as a raised roll border with central ulceration. The keratin is at the borders, it's not in the center. This differentiates from the squamous cell carcinoma. In the squamous cell carcinoma, the keratin is inside the ulcer. In the basal cell carcinoma, it's at the borders, and may be pruritic. There are some subtypes that we should know. They are less common. Is, for example, the scar-like lesion in an area that has never been injured. You can suspect a basal cell carcinoma. An area normal appearing skin that repeatedly ulcerates and heals. And also the pigmented, it can be a pigmented one with benign melanocytes. That has to be differentiated from a melanoma. This is the histology of the basal cell carcinoma. We have different growth patterns. We have the nodular form. Here we see the nodular form at the top right, and the microcytic growth of the basal cell carcinoma invading the basilar membrane. And we see in this one that we see the cells better. There is a nest of uniform dark basaloid cells with big dark nuclei. Big dark nuclei is typical of cancerous cells. And this is a board question. They like to ask this. They have the palisade pattern at the periphery of the tumor, the basal cell carcinoma. That makes it easier to distinguish from other types of cancer. And it's believed that these cells, these cancers, they arise from the basal cells of the epidermis and from epidermal appendages. And the characteristic of this cancer is that it invades the dermis but doesn't give metastasis. And why? Because these cells, they need proteins from the dermis. They don't survive in the lymphatic system. They don't survive in the blood. They need some nutrients that they are present in the dermis, but they are not present in other areas. That's why they are locally aggressive, but they don't give metastasis. This is the squamous cell carcinoma of the skin. That is also common in the face, on the face area. We have two different types. It's the well-differentiated because it has keratin and it has a dermal invasion by a broad round tumor margin. And we have the poorly differentiated that is more difficult to diagnose. It has no keratinization, no cellular organization with blurred borders. And this tumor doesn't need the nutrients of the dermis to survive, and that's why it spreads. It spreads via the lymphatic channels to regional lymph nodes. There is no interaction with surrounding stroma like the basal cell carcinoma, and allows this tumor to grow in other tissues. This is the histology of the squamous cell carcinoma. And we see that the keratin is in the center, it is within the tumor. It's not at the borders. In the basal cell carcinoma, it's at the borders. In the squamous cell carcinoma, it's within. There is a process called dyskeratosis. Is when the keratin starts to be developed, form in the basal layers of the skin. You can see it here, and this is very typical of squamous cell carcinoma. And we have these keratin pearls. Then the other very important tumor to know is the melanoma. And melanoma is key to the early diagnosis, and we have to be very aware, especially in light-skinned people, not only in light-skinned people, but especially in them, that they kill people. And then you have to diagnose early the melanoma. Maybe a soft macule, or may have a firm elevated surface, as in the nodular melanoma. And the ulceration is important for the melanoma because it's important for the staging and for the prognosis. Adds a B letter in the staging. And the satellite lesions are a strong predictor of malignancy. When we see satellite lesions, it's very highly likely that this is a melanoma. And when you see these lesions, you should make an excisional biopsy. One more question is, what kind of biopsy do you do for the melanoma? Don't do a safe biopsy, don't do a punch biopsy, don't do an incisional biopsy. You have to do an excisional biopsy. This is a malignant tumor. And then the melanoma has different signs to be able to recognize a melanoma. These are the A, B, C, D that we should very well know. And the A comes from asymmetry, is when one half of the lesion doesn't mirror the other. Border irregularity is when the edge of the lesion is indistinct or variegated. There is a color change inside the lesion, and when the diameter is bigger than 6 millimeters. And these are examples of all these ABCDs. Then talking about aging skin again, and this is the histology, the main changes of the aging skin. We see that there is a epidermal thickening with deep wrinkles. We see that there are some keratinocyte atypia in the epidermis with loss of polarity. The melanin is irregularly dispersed in the epidermis. And we see that the elastic fibers and the collagen, they break. And then we have aggregated elastin and atrophy of the collagen structure. And there are many studies of aging skin, histological studies. We see the flattening of the dermal epidermal junction of the skin, and there is a diminished area of contact between the dermis and epidermis, and this is related to a predisposition for separation along these interfaces. And then having this layer flat, it means fewer basal cells per unit surface, and decreasing the number of available keratinizing cells. Less available keratinizing cells means dry skin, means poor wound healing, noted in the elderly. And we have the landmark of the aging skin, the solar elastosis in the reticular dermis. Also, in this study shows the cellular heterogeneity of the epidermal keratinocytes with variation of size, shape, and staining qualities in the epidermis. There is a disruption in the orderly keratinocytic differentiation with a loss of polarity. And these alterations reflect the increased incidence of epidermal neoplasms among the elderly. The melanocytes in the elderly, they are larger and they aggregate. They make clusters, and these clusters, they give rise to lentigines. And they have a variable degree of nuclear atypia with a variation in size and in shape. And this aggregation of melanocytes explains the inability of the elderly to tan as deeply or evenly as in the young people. They tan just in aggregate areas. The dermis changes with the aging skin. We talked already the dermal elastosis or solar elastosis. This is produced by ultraviolet damaged fibroblast. And there is a development of cystic spaces between these fibers. And there is a progressive separation of these elastic fibers. The collagen decreases linearly by 1% per year, and they arrange in thin bundles. And the ground substance, the glucosaminoglycans and proteoglycans, decrease rapidly in early life. There are some studies during the childhood is when the ground substance decreases. Then the population of the dermal cells decreases, the fibroblasts decrease, and there is increase in inflammatory cells, the mast cells, that they start to degranulate pro-inflammatory molecules. And there is a sign in aging skin exposed to sun that is called chronic heliodermatitis. It's a chronic inflammatory changes in the skin. Then in the 60s, in the Sinai hospital, there was one facial dermatologist that started to use peelings for aging skin and to study the changes after the peelings in the skin. He used a phenol solution and he did punch biopsies after these peelings. In the 80s, Dr. Klickman is a famous dermatologist because he was the one relating the sun exposure to aging skin. And Dr. Klickman did a very thorough study of histology about phenol-treated skin. He had skin strips of facelift patients that he took to study, and these patients, they had before a peel, and then he studied the effects of the skin after the peel. And then we have here the unpeeled specimen with intense elastosis. I think it's time to, yeah. Okay. Yeah, I just received one text from Kim that it's time to finish. Okay. Well, thank you very much, everybody. And I'm going to stop my presentation. And I would like to acknowledge the facial plastic surgery department for the inspiration, and the entire department. Thank you very much for all the help.
Great talk, Rodrigo.
Yeah.
Very in-depth. How's this going to guide your decision-making and treatment of your future facial plastic patients?
Well, I think this shows me that it's very complicated to treat the aging skin, and I would say that there is no really specific measurements to treat or to prevent aging skin. There are some norms like general healthy lifestyle that they are very well accepted, but the leap to give a specific recommendations for nutrients is a challenge. It's not very well known how to recommend a specific guidance to aging skin patients. We recommend healthy lifestyle recommendations, but I think that's good enough so far. Maybe in the future we will need some very large scale studies.
Okay, yeah, I'd agree. I mean, I think there's a lot we can do for patients. The thing that I sort of take away when I hear a talk like this that's very in-depth is just to remember, you know, you're an otolaryngologist first. That's what sets you apart from some other plastic surgeons. So when you're looking at your patients, you know, you can't overlook some of these things that might be precancer or cancer, and you got to look with that lens and don't forget it.
Yeah.
Yeah, Rodrigo, nice talk. I know we're short of time, but just wanted to commend you on the talk.
Thank you.
Yeah, thanks, Rodrigo. We are short on time. I did want to make a quick announcement about the OR situation. So I think the faculty got the email that there was a new order, emergency medical order put out by the California Department of Public Health, that they wanted to cancel all elective surgery, even outpatient surgery. And unless it was being done in a non-hospital-based ambulatory surgery center, like the Beverly Hills Surgery Center. And of course, the hospital CEOs around the state got really upset at that, because all it's doing is moving business out of their hospital. And it doesn't actually solve the problem of opening up more beds in the hospital. And so they're meeting again right now at 8 o'clock this morning, all the CEOs with the California Department of Public Health. But it seems like the general thought is that as long as a patient is having surgery and does not need a hospital bed, so pure outpatient, purely done in HC4, they're going to let those continue. But if a patient needs 23-hour OBS or any hospital bed, then we have to use that priority ranking, and it would be a tier 3, which is basically our emergency airways, it's our head and neck cancer, and it's our you know, infections that are kind of getting out of control quickly. Questions on that? So the good news is it's basically where we were doing before. So we'll see if things change today, but as of right now, that's the plan going forward. So cases will still be going in HC4. Thanks.
John, how far out should we be bumping our rescheduling? How far out should we be rescheduling?
Yeah, so they're talking 3 weeks right now. I have doubts based upon what I've been seeing in the curves, what I've been hearing about a lot of travel over the Christmas and New Year's time, and it might very well be more than 3 weeks before they let us do inpatient cases again. Inpatient elective cases, I should say. Thank you.
Okay, so I think we're going to move on to our guest speaker today. We have the honor of having Dr. Jacob Thomas, who is one of our very own hematology oncologists at USC and County. So for those of you who don't know Dr. Thomas, he through our tumor boards, he has taken on a major role in helping take care of our head and neck cancer patients with rather advanced disease and multidisciplinary approach. So Dr. Thomas went to BYU for undergrad. Then he went to University of Illinois College of Medicine. He did his internal medicine residency at UCLA, followed by fellowship here at USC Norris. Then in 2018, he joined on as faculty and practiced also at County. So we thought it would be beneficial to learn about the medical side of treatment for our particularly advanced stage head and neck cancer patients that require multidisciplinary approach to management. And we are excited to have him talk to us today about systemic therapy for head and neck cancer. So please give your undivided attention and let us welcome Dr. Jacob Thomas.
Okay, well, thank you. I'm happy to be here with you virtually. Hopefully I get to meet a lot of you in person someday. But for the time being, this will definitely do. So I appreciate this opportunity I have to get to meet with you and share some things about systemic therapy for these patients. And you know, it's a very broad topic, of course, and so I'm focusing just on head and neck squamous cell cancer. You know, it's the most common histology that we see, and trying to give you guys a broad overview, just so you have a broad understanding of you know, what we do with the patients when you send them over to us after surgery. Or what we do for the patients when they have advanced disease that's no longer surgically resectable. And so first off, can everybody see my slides? Just make sure that everything's showing up correctly. Okay, good. So so this is the outline for what I'm going to cover today. First, I'm going to just review some of the common drugs that we give. So you can have an understanding of the types of side effects that we see with these drugs, the things we have to think about when we're selecting which therapy to give to patients based on comorbidities and possible side effects and how well they're going to tolerate things. Then specifically, we'll talk about locally advanced disease, you know, how we select patients for treatment, how we decide what drug to use. There's a big debate right now about whether we can de-intensify therapy for HPV positive patients since they have a better prognosis. So we'll talk about where things stand for that right now. We'll talk about the role of systemic therapy in larynx preservation. And then to end with, I'll give you guys a brief overview of relapsed metastatic disease and the current standard of care and some future directions for where we're going in that space. As I go through all of this, I know with this format it can be hard to be interactive and get things out of it, but I want to make sure I cover what's important for you guys and answer questions that you guys might have. So feel free at any time as I'm going through this. If I'm going too quickly through something or something's not clear, please, you know, stop me, ask questions, or we can have a few minutes at the end to answer any questions if I don't bring up something that you have a question about. So please stop me as I'm going. So going into the common systemic therapies. So first off, if there's any drug that you need to know about in head and neck cancer, it's cisplatin. This is an old-fashioned chemotherapy drug. It's been around for a very long time and is still the most common drug that we're giving to patients with head and neck cancer. So this, as I always tell patients, this is old-fashioned chemo. This is a cellular poison. You can see here that its target is DNA, and what it does, it covalently binds to the N-terminus of the DNA and will cross-link, and by doing that causes DNA damage. So this happens in the cancerous cells as well as healthy cells, and that's why we have toxicities. The idea behind this and all chemotherapies is that cancer cells are unable to handle this DNA damage as well as healthy cells. And so they're more susceptible to cellular death from causing this kind of DNA damage. So the toxicities of cisplatin, being an old-fashioned chemotherapy, are pretty great. So this diagram here shows you just the degree of these systemic toxicities. And really, it's multi-system toxicities that we see with cisplatin. So I'm going to go through a few of the most important ones in detail that I think are good for you to understand kind of what your patients are getting into when you send them over to us for adjuvant chemotherapy. So nephrotoxicity is a big one. We worry about this most in older patients or patients with comorbidities, underlying renal disease. Cisplatin is excreted mainly by the kidneys and then will cause damage to the kidneys as it's being excreted. And so the main way that we prevent this is by giving a large amount of saline infusion both before and after receiving the cisplatin. So a lot of patients complain that when they get cisplatin, it's a very long day. And this is the main reason why. So every dose that the patients get of cisplatin, they get 1 to 2 liters at least of saline with a bolus before and after the chemotherapy. The cisplatin itself is only about an hour, but because of all the saline infusion that they get before and after, it ends up being about a 6-hour day. So on the days that they're getting the chemotherapy, in addition to radiation, they're pretty much with us the entire day. And that's the main reason. If we do this, we're able to prevent nephrotoxicity in most patients. So we actually don't see rising creatinines too often with doing this. But this can be an issue for patients with heart failure that can't receive this large amount of saline infusions. And then patients with underlying renal disease or liver disease that giving this amount of fluid can be problematic. So that's something that comes into play when we're assessing a patient for cisplatin. Neurotoxicity is another one. This is something that affects mainly the longest nerves in the body, and so it manifests mainly in peripheral neuropathies in the hands and the feet is the most common manifestation. This doesn't happen until the end of treatment. In fact, a lot of times patients will develop neurotoxicity after they've already completed the course of therapy. And it can continue to get worse even for a month or two after finishing, and then it can take several months for it to get better. And some patients can have long-term neurotoxicity. This most often is mild peripheral neuropathy, which could just be some paresthesias in the hands and feet. But some patients occasionally can have really severe peripheral neuropathy, severe pain, making it difficult to walk or to use their hands. This tends to happen after receiving more than a total cumulative dose of 300 milligrams per meter squared. That's about the maximum that we'll give for head and neck cancer patients. So it's a bigger issue for other patients that receive higher total doses of cisplatin. So we do see this in head and neck cancer patients, but not as much. If patients do start to develop this or develop it after they've completed their therapy for head and neck cancer, gabapentin, Lyrica, other types of antidepressants can be helpful for managing it. These don't reverse the course of the neurotoxicity, but they can help the patients manage it until it improves, because again, it can take many months for this to recover. So ototoxicity is something else that we talk about for all patients with cisplatin. We routinely will send patients to audiology for baseline screening prior to getting cisplatin. The ototoxicity also is dose dependent, similar to the neurotoxicity, and is typically manifested as high frequency sensory neural hearing loss. So in my experience, most patients may not even notice any major changes in their hearing functionally, but if we repeat their audiology testing before and after, you can definitely see a difference. It's almost always bilateral, as you'd expect. Patients that develop this often can develop tinnitus or vertigo in addition to the hearing loss. The total incidence that's reported is 10 to 20%. And this can be additive with radiation, depending where the radiation fields are and how much they include the inner ear. And this is what's reported, but again, in my personal anecdotal experience, I think that this incidence is higher, and this is based on formal testing, which we don't always do after completing. Functionally, I think it's pretty rare that there's severe enough ototoxicity that it causes a functional change in how patients can hear. And that's in people that at baseline don't have any major hearing issues. If people at baseline have poor hearing, then those patients definitely this can push them over the edge and cause more severe issues. Here, this is a table just to kind of go through some of the other toxicities that we see. And what this does, it's a little busy, but I'll just walk you through it. This is from a clinical trial comparing radiation alone versus radiation plus cisplatin. So if you take a look at the columns A and B here, the column A is patients that received adjuvant radiation alone. And then column B is patients that had radiation plus cisplatin. The toxicities here are graded. And in oncology, the toxicity grading system that we use, basically grade 1 and grade 2 are mild or mild to moderate respectively. Grade 3 or 4 are more severe issues. Grade 3 tend to be things that are clinically significant that might cause us to need to change our therapy or provide some supportive care. Grade 4 toxicities would be possibly requiring hospitalization or life-threatening, and grade 5 is a toxicity causing death. So here you see all of these toxicities that are reported are mainly grade 3 or 4, so pretty significant toxicities. And these are percentages that you see here. So with radiation alone, you see that severe nausea and vomiting, not extremely common. Significant mucositis dysphagia, 32%. Overall, if you see all grade 3 to 5, 51% of patients with just radiation have these pretty serious toxicities. You see when we add chemotherapy, that total, if you look at all grade 3 to 5, goes up to 85%. So adding cisplatin to radiation significantly makes things more difficult. Specifically, and you can see the p-values over there on the right. So there's statistically increased nausea and vomiting, leukopenia, cytopenias, definitely renal toxicity, and then all of them put together statistically significantly more toxicity. So this definitely comes into play when we're looking at patients, based on their performance status, comorbidities. We know that it's going to be a lot more difficult for them to complete the course of radiation if we add the cisplatin. And so if we're worried about somebody's performance status, then that may encourage us to hold the chemotherapy so that they're able to finish the radiation alone. So moving on to another common drug you'll see for head and neck cancer, carboplatin. So you can see the chemical structure here, very similar to cisplatin. It's basically a cousin molecule. So the mechanism of action is the same. The modifications to the drug have led to improved tolerability. So you can see it has decreased amounts of nephrotoxicity, neurotoxicity, ototoxicity, nausea, fatigue, but along with all of that, also decreased efficacy. And so carboplatin, really the way that we think about it is for head and neck cancer patients in the adjuvant setting, we really only consider using this for somebody who has a marginal performance status or has some other contraindication to cisplatin. So for example, I have a patient right now that I'm treating that had baseline pretty severe hearing loss. And he had some mild renal disease as well. So we substituted carboplatin for cisplatin in that patient. Patients with renal disease are another common reason we might substitute carboplatin. Or patients with heart failure that can't handle all the fluids that they would get with cisplatin. That might be another situation we would consider using carboplatin. But again, head-to-head trials to cisplatin have all shown decreased efficacy, worse outcomes compared to cisplatin. So if patients are fit, otherwise we would never consider using carboplatin. So cetuximab is another.
Jacob, can I ask you a question?
Yeah.
Moving to the next level. Frequently patients ask, I mean, you guys decide giving, some patient get weekly, some patient gets 3 doses during the course. They always ask me, what is the right thing to do? So would you make a comment on that?
That's a great question. You know, I'm gonna, I'll come back to that in a minute if that's okay, because when I go through the locally advanced section, I talk about some of the data between those 2 dosing regimens and when we consider using them. So it's a great question. I'll come back to that because I have some slides that address that. So cetuximab is another very commonly used agent in head and neck cancer. And this targets the EGFR receptor, which is a transmembrane receptor. And you can see here, it's a busy slide, but really what this illustrates is this has many downstream effectors that, that lead to cell survival and growth and differentiation of cancer cells. And so that's really the key here with this, this diagram. So targeting EGFR is the goal is to block all of these downstream effectors that can then lead to apoptosis of the cells and decreased growth and survival. So the main toxicity, if you don't take away anything else with cetuximab, is it can cause a severe rash. And I have some pictures on the next slide and go into that in more detail. It can be very severe and very morbid in patients. So that's the biggest issue that we see with cetuximab. It can also lead to some magnesium wasting. So we have to follow that and replace magnesium in patients. There are some patients that have infusion reactions, so allergic type reactions while getting the infusion, but otherwise fairly well tolerated. It doesn't cause nephrotoxicity, neurotoxicity, bone marrow suppression, myelotoxicity. And so in patients with renal disease or severe diabetes and peripheral neuropathy, this could be an alternative agent we could consider. So the rash, you can see here some examples associated with cetuximab. So on the left, you can see grade 1, so the mild rash. It just kind of looks like an acneiform type rash, really not very bothersome. Often can be handled with topical, either topical antibiotics, sometimes oral antibiotics, or topical corticosteroids in some cases. Same thing with grade 2, you can see just more pronounced, more severe acneiform rash. But then if you look at grade 3, you can see that occasionally we have pretty morbid rashes that we can see with patients. Very uncomfortable, can be very itchy, painful, can lead to secondary infections and cellulitis. And so this is something we counsel patients on. You know, they think, oh, it's not chemotherapy, this is going to be easy. Well, there's a pretty significant incidence of these types of rashes that can make it very difficult. When you add this to radiation, the skin toxicities get even worse because the radiation kind of sets things up for the inflammatory skin reactions to happen. And so it's actually pretty difficult for patients to receive cetuximab and radiation, even though it's not a chemotherapy. So I tell people that that they think they want to do something easier than chemotherapy. It's not necessarily that much easier to handle than cisplatin. The last systemic agent I want to talk about are the checkpoint inhibitors or immune therapy drugs. This is the biggest, most exciting development really in oncology in the past 20 years. These agents are very different from the chemotherapies or targeted agents that we've discussed so far. Checkpoint inhibitors are working on this PD-1, PD-L1 axis that you see represented here. Simply put, the T cells can recognize the tumor cells, but the tumor cells express PD-L1, which inhibits the activation of the cytotoxic T cells. And by binding PD-1 and preventing this interaction, you take off the brakes of the immune system and allow the T cells to recognize the cancer and attack and cause apoptosis. This can be extremely effective in certain patients. It's still the minority, which we'll discuss later, but we've made a lot of progress, and some patients are able to have long-term survival with this type of treatment, which is very different from cytotoxic chemotherapies. Toxicities that you can see here, pretty well tolerated overall. You can see the severe toxicities, grade 3, 4, or 5, only about 13%. The main toxicities that we see with the checkpoint inhibitors are autoimmune type diseases. So really, if you just think any type of autoimmune disease, they have been reported, and we see these. The common autoimmune toxicities that we see are hypothyroidism. A lot of patients end up needing to take thyroid supplementation after being on checkpoint inhibitors, but that's very easy to manage. Other common things we see are pneumonitis, skin rash, colitis, and hepatitis are some of the more common things that we see. But still, the incidences are fairly low, and so even elderly patients are able to tolerate checkpoint inhibitors pretty well. Okay, so moving on to locally advanced disease. I wanted to start off with kind of a summary slide, and then we'll break down into more details. But this, I think, has some key points for you to take away. Starting at the top, we see here. So this is from a large meta-analysis that was done using about 100 different clinical trials in head and neck cancer using systemic therapy in a few different settings. And so over the 80s and 90s, a lot of these trials were done trying to figure out how best to use systemic agents in both the adjuvant setting or the definitive concurrent chemotherapy and radiation setting. And so you can see different strategies here, and they were all broken down into 3 basic categories: using induction chemotherapy, using just adjuvant chemotherapy alone without radiation, or using concurrent chemotherapy and radiation. And so you can see this meta-analysis. Looking at induction chemotherapy, there was no significant survival benefit. They did not meet statistical significance. And so induction chemotherapy is not a standard recommendation because there's no survival benefit. I'll talk about later on some instances where we consider it, but we don't consider it to improve survival. Adjuvant chemotherapy, there's been several different trials using different regimens, different ways of giving adjuvant chemotherapy, have never been able to show a survival benefit. And so that's why you'll hear us say in Tumor Board that there's really no role for adjuvant chemotherapy alone, because we just don't have any data to show that it's ever improved survival. Concurrent chemotherapy and radiation, though, there is a survival benefit definitely, and that's been shown again and again through many different trials with different agents, different radiation regimens, but pooled all together, the survival benefit that we quote to patients typically, the additive benefit of chemotherapy to radiation is at least a survival benefit of 6.5%. Some studies suggest it's a little bit higher than that, but again, pooled all together. So typically I'll tell patients that the benefit of adding chemotherapy is likely somewhere between 5 to 10% in addition to the radiation. But that's kind of one key takeaway I wanted you guys to take from the talk, is that adding the chemotherapy can cure about an extra 5 to 10% of people. In addition to improving survival, you can see on the graph on the bottom that this is looking at the rate of failure, looking at both local failure or distant failure. So you can see, as you might expect, most of these patients with head and neck cancer are going to be having local recurrences. And so adding systemic chemotherapy can prevent about 10% of these local recurrences. And then the distant failures, it's about 2.5%. But there's definitely a benefit of preventing distant recurrences also. The two largest studies that we look at for adjuvant chemoradiation were the EORTC and RTOG studies here. And they both had different criteria for selecting patients to receive adjuvant chemoradiation. And so you can see here the factors that were only in the EORTC, the factors that were only in the RTOG. In the combined analysis of the two, the only two factors that were shared between these two studies were patients that had positive surgical margins or patients with extracapsular extension in the positive lymph nodes. And based on the combined analyses of these two studies and others, these are the factors that consistently show a survival benefit for adding chemotherapy to radiation. And so based on these studies, these are really the patients that we're looking at as high risk. And so the positive, these are where you see the most survival benefit. And if there's no E&E, we really don't see that.
Hey, Jacob, I have a quick question on that.
Yeah.
For the E&E in those studies, how did they measure it? Did they, measure more than 2 millimeters, more than 3, or was it just a plus or minus? Because we always kind of wonder what to do for very small E&E versus embedded lymph nodes.
Right. Yeah, it's tough. So I've looked at this question in these studies, and it's a very simple binary definition is what they used. And so we really haven't addressed that in these large studies, but that's something that definitely concerns me. When we're seeing patients that have, yes, there's E&E, but it's less than 2 millimeters. We see that often. And maybe they only have one lymph node with a very small focus of E&E. I mean, clearly that's different than somebody with a 3 centimeter lymph node with gross E&E. But unfortunately, in these studies, that wasn't addressed, and we don't have subset analyses looking at those types of those cases. So that is something I look at. We don't really have evidence, but I consider that when I'm looking at a patient, in addition to their comorbidities and overall status. So this gets back to Dr. Sinha's question. That's a frequent question that patients have as well. What dose of cisplatin should we use? What regimen should we use? Historically, the dose of cisplatin that was used was high dose cisplatin, 100 milligrams per meter squared, given over 3 doses, day 1, day 22, day 43 of the radiation course. So that's every 3 weeks. this is highly toxic. It's very difficult to tolerate even for young, fit patients. This is still category 1 evidence. Most of those clinical trials in the meta-analyses were using this dose. But when we look at these trials, less than half of patients in these studies actually were able to receive all 3. So the majority of the patients in these trials were able to get 2 of the doses. And so when I do use this dose for patients, I try to at least get 2 of the doses in. And in these studies, if the patients didn't receive the 3rd dose, that doesn't seem to affect the disease-free survival. And so at least if we can get those 2 doses in, then I'm happy. But still, we try to get in as much as we can. There was some controversy in the past few years about using lower doses. One of the largest prospective randomized controlled trials looking at a different dosing schedule was a trial done in India. And this trial randomized patients to a weekly dose of 30 milligrams per meter squared versus the high dose 100 milligrams per meter squared every 3 weeks. Most of these patients were adjuvant, primarily oral cancer, which is very prevalent in India. This study showed definitely improved local regional control with the high dose and worse with the weekly. So overall, much better outcomes with the higher dose compared to the weekly, but toxicities were significantly worse with the high dose, as we expect. So there's some criticisms with this study. The weekly dose of 30 milligrams per meter squared, a lot of people think is too low. We more commonly give 40 milligrams per meter squared. Also, since this was primary oral cavity cancers, it's unclear if this can be fully extrapolated to our patient population here, which is slightly different. And that brings us to actually this year, there was kind of a practice-changing study reported at ASCO. And this was a study done in Japan using a high-risk population more similar to what we see here in the US, both HPV positive, HPV negative, and a good representation of different primary sites. And all of these patients were adjuvant. So this study compared the weekly 40 milligrams per meter squared versus the high dose 100. It was a large study, 200 or 300 patients, and it showed non-inferiority with the weekly 40 milligrams per meter squared dose, but significantly improved tolerability. So after this study has been reported, myself and a lot of us in the medical oncology community are feeling more comfortable using the weekly cisplatin dose in the adjuvant setting. And this is quickly becoming the new standard of care. And so I'm considering using weekly cisplatin in all of my patients getting adjuvant therapy. Now this may not apply to the definitive chemotherapy and radiation setting. We don't have data showing that there's non-inferiority using the weekly dosing there. But in adjuvant, at least, I'm now using weekly cisplatin for all of my patients. So Dr. Sinha, I don't know, does that help to answer your question?
Yes, thank you very much. Yes.
And then also, as I mentioned before, carboplatin is definitely inferior. There's the reference there. And so no question, it's an inferior drug, inferior outcomes, inferior survival, and local control. But again, if patients are unable to tolerate the cisplatin, we consider it. So as I mentioned, dose intensity does matter, and specifically for HPV negative patients. So kind of a busy graphs here, but if we look at the top left, this is HPV negative patients receiving cisplatin chemoradiation. And you can see the red dashed line is patients that receive less than a total of 200 milligrams per meter squared. So that might mean they only got 1 dose of the high dose, or they had to receive lower doses. The blue one is patients that had exactly 200 milligrams per meter squared, so they got at least the 2 doses of the high dose. And then the green are people that got more than 200. So for HPV negative, you can see survival is significantly improved with the more cisplatin that you get. What's interesting is on the top right, if you look at HPV positive patients, that difference actually falls away. So it's less clear how important it is to get that dose intensity for the HPV positive patient compared to HPV negative. So when I'm treating my patients that are HPV negative, I definitely are going to be pushing a lot harder to get as much of the chemo in as I can. For HPV positive patients, if they're struggling, having a harder time getting through it, I can be a little more lax and feel more comfortable with it. So now cetuximab. So this is the data showing that using cetuximab along with radiation definitely improves survival. This is a study in stage 3 and stage 4 patients receiving cetuximab and radiation. And you can see there's about a 9% survival benefit. So definitely a significant survival benefit there. The toxicities you can see on the bottom when we add the cetuximab, significant amount of severe skin reactions, way more than with just radiation alone. So that's the main issue with this. And as I said, it's really not necessarily easier to tolerate than getting cisplatin because the rash can be really, really severe. So touching on now HPV positive patients and de-escalation. So as you know, the prognosis of these HPV positive patients is better than HPV negative, and that's led to a desire to de-intensify the therapy to try to prevent morbidity and toxicity in these patients. So this is one of the largest phase 3 trials that's been reported. In this trial, they took patients that were HPV positive, stage 3 to 4, that have low risk based on smoking history and lymph node involvement. And they randomized these patients to receiving cisplatin versus cetuximab plus standard radiation, 70 gray. And it's pretty clear that there's a decrease in overall survival using cetuximab. So we were all hoping that we would be able to, de-intensify the therapy and spare some of these patients some of the long-term toxicities with cisplatin. But unfortunately, based on this, we're not able to substitute at this time because clearly there's decreased overall survival. So right now, this here is a schema of a phase 3 study that's going on right now to try to further study de-intensification in HPV positive patients. We have this study open here at USC. And really what this is looking at are the lower risk HPV positive patients. You can see T1 to T2, N1, or T3, N0 to N1. And these are patients with less than 10 pack year smoking history. And these are patients that are not getting adjuvant, but are getting definitive chemoradiation. And so we're randomizing the patients to standard of care cisplatin plus standard radiation versus a shorter course of radiation plus cisplatin, or a shorter course of radiation plus nivolumab, which is a checkpoint inhibitor. So this study, we will see in a couple of years if we're able to decrease the radiation that we give to these HPV positive patients, or if we're able to substitute a checkpoint inhibitor. So this is the biggest study that's going on right now, looking at de-intensification. Right now in the adjuvant setting, we don't have any other trials looking at that, any other big trials looking at de-intensifying for HPV positive patients or looking at other regimens. So for right now, adjuvant patients, it's all standard of care, cisplatin and radiation. But we'll see in a few years with this large study, and I'm sure there's going to be more studies coming using checkpoint inhibitors in this setting. So to summarize concurrent chemotherapy and radiation, we consider chemoradiation with positive E&E or positive surgical margins, and the weekly cisplatin 40 milligrams per meter squared is preferred in the adjuvant setting. As I mentioned, in the definitive chemoradiation setting, the standard of care is still the high dose 100 milligrams per meter squared every 3 weeks, but we consider the 40 weekly in some patients, but there's not strong data for using that. Moving on to, I'm just taking a look at the time, to induction chemotherapy. So as I mentioned, there's no proven overall survival benefit versus using concurrent chemoradiation. So it's not considered standard of care to use routinely. But we do consider this in some patients. One thing that comes up in tumor board a lot is, well, patients aren't a surgical candidate right now. Maybe they just had a stent placed. That's a pretty common scenario. They have bad CAD, just had a stent placed, or for some other reason, we're not able to get them to the OR. Or right now in the era of COVID, maybe we're having delays with OR schedules and we need to buy patients some time. So then it could be reasonable to consider induction chemotherapy. The most common regimen is called TPF. It's listed there on the bottom. 3 different chemo drugs, docetaxel, cisplatin, and 5-FU. I won't go into the details of the regimen and specifics of side effects, but the takeaway I want to give to you guys is it's very toxic, very difficult for patients to get through. So we really consider giving that full regimen only in kind of young, very fit patients. But if they are able to tolerate it, the response rate is very high. So it's 72%. So almost 3/4 of patients are going to have a definite good response. So if we're hoping to, either buy time or, decrease the bulk, we have a pretty good shot at doing that with this. But it's tough for patients to get through. Moving on now to larynx preservation. So this is a classic study that probably a lot of you are familiar with. It's called the VA study. And this was the first study to demonstrate that there was not decreased survival using a chemotherapy and radiation approach versus going straight to total laryngectomy. So you can see here on the left that the disease-free interval is comparing patients that had chemotherapy followed by radiation versus patients that went straight to laryngectomy. So the dotted line is the patients that went straight to laryngectomy. The solid line is the patients that had chemotherapy followed by radiation. So you can see that the patients that went straight to surgery had a greater disease-free survival. But then when we look at the figure on the right, the patients with surgery and with the chemotherapy and radiation approach had similar survival. So this was kind of the first proof of concept that we could potentially preserve the larynx in some patients without compromising survival, although, some of these patients that get the chemotherapy and radiation are going to have to go on to salvage laryngectomy. This was followed up by a study, the RTOG 9111. So this had 3 different arms. You had patients that had an induction chemotherapy at the top. If they had a good response, then they would either go to more chemotherapy followed by radiation, or if they didn't have a good response, they'd go to surgery and then get adjuvant radiation. Then in the middle, we had patients treated with just concurrent chemotherapy and radiation, and then on the bottom, just radiation alone. So if we look at the outcomes, the primary endpoint of this study was laryngectomy-free survival. And we see here that the curves for radiation and chemotherapy overlap. So treatment with either induction chemotherapy or concurrent chemotherapy and radiation gives pretty good laryngectomy-free survival, definitely improved compared to radiation. And then you see that there's no difference in overall survival. So summary for larynx preservation, concurrent chemotherapy, radiation, or induction are both acceptable strategies based on these studies. These can improve larynx preservation, but compared to going straight to total laryngectomy, there's never been a proven overall survival benefit. Selecting these patients is important, and that's why we always, need to discuss this in a multidisciplinary fashion. If patients have poor baseline laryngeal function, then it's maybe less likely that we're going to regain laryngeal function by doing a larynx preservation strategy. So for patients with T4 lesions or very poor function, it may not be worth it to go down this route. It may just add to their toxicity versus going straight to laryngectomy. But you all, I'm sure, know more about that than I do, I'm sure. For the last couple of minutes here, want to just give you guys a brief overview of what we do with patients in the relapsed metastatic setting. So again, immunotherapy is our golden knight here on the horse coming in to save the day. This is something that a lot of patients are really excited about, a lot of physicians are really excited about, and has just become the new standard of care therapy for relapsed metastatic head and neck cancer as of 2019. So the main study that I want all of the medical oncology fellows to know backwards and forwards is the KEYNOTE-48 study. And this study looked at patients with head and neck cancer that were considered incurable by surgery or radiation. So they may have locally advanced disease, not amenable to surgery or radiation, or they may have metastatic disease. And we randomized patients to getting checkpoint inhibitor alone at the top, checkpoint inhibitor plus chemotherapy, or the extreme regimen, which used to be our standard of care, which was cetuximab plus chemotherapy. And the main takeaways that we see here, the top graph is comparing pembrolizumab versus the extreme regimen. And this is the overall survival curve. So we see that overall survival was better with the checkpoint inhibitor versus the extreme regimen. Now, the difference between the top and the bottom graph, we're separating patients out by their PD-L1 expression. And so if you remember the checkpoint inhibitor pathway, it blocks the PD-1, PD-L1 axis. And so the greater degree of PD-L1 expression on the tumor can predict the response. So on the top, we see patients that have greater than 20% expression. On the bottom, it's just greater than 1. So we see the higher the expression of PD-L1, we see improved overall survival and improved response rates. On the right, you can see the response rates. And this is something I think is important for you to know kind of what percentage of patients do we expect this to actually work. As excited as we are about immunotherapy, it's still really effective only in a minority of patients. So the overall response rate, meaning, what percentage of patients do we actually see a reduction in size of the tumors? 23% at best for the patients that are expressing PD-L1 highly. Those that it's just greater than 1, 19%. A CR is a complete response, meaning there's no radiographic evidence of cancer. So you can see in the high expressors, we see that in 8%. And these are the patients that potentially could be cured from the immunotherapy. So 8% chance maybe if you have high expression, 5% chance maybe if it's just greater than 1. The overall survival that you can see here, the median is 14.8 months for the high expressors, 12.3 months for not. So again, the likelihood of success, unfortunately, is still very low. But for patients that do have a good response, they can have very long-term survival. If you notice on the x-axis, this survival curve goes almost out to 50 months. So we're seeing very long-term survival in these patients that have a response. This just is an example of a complete response that we see. This is a patient with maxillary sinus cancer. And you can see on the top compared to the bottom, this was considered a complete response. So you can see a significant reduction in the size of the malignancy here in these different areas. So to summarize, one thing I didn't go through in great detail, but HPV status doesn't predict for response, only the PD-L1 status. And for patients that are expressing PD-L1, we have this option of giving immunotherapy. If the patients don't present express PD-L1, our standard is to give immunotherapy plus chemotherapy. So that's our current standard of care. That's what we're offering to all of our patients in the relapse setting. What do we do for patients that progress on this, and how can we improve upon this? Because really we're looking at only 20% of our patients maybe having success with this immunotherapy approach. So how can we improve upon this? So right now there's lots of clinical trials ongoing. We have here at USC, and we're opening up new ones using novel immunotherapy combinations. So there's novel combinations using both intravenous drugs, oral drugs. We're opening now a drug that's using an intratumoral injection, where we'll actually inject immunotherapy agents directly into palpable tumors in combination with the IV checkpoint inhibitors. We have novel targeted therapies that are coming through the pipeline, particularly for KRAS mutant patients. About 5% of head and neck cancers have mutations in KRAS, and we've got a drug that's showing great promise for targeting those patients. So that's something that could become a new standard of care in the next few years. Another thing that we're doing here at USC is using TILs, or tumor infiltrating lymphocytes. And this is something that we'll do together, partnering with the surgeons. Patients will need a surgically resected tumor that then will isolate the lymphocytes that are infiltrating into that tumor, expand those, and then infuse those back into the patients. And we've been having some great success with that therapy. It's a pretty intense therapy, but we've had patients with complete responses and complete resolution of their metastatic cancer using that. So that's a new therapy that we're doing on clinical trials that's definitely showing promise also. So that brings us to the end, and it looks like we're about right on time. So happy to answer any other questions that you guys might have.
Thank you, Jacob, for a wonderful presentation. A couple of, I'm curious to know the PD-1 expression. Is there any difference between, a technical question, can you differentiate with the fresh tissue versus when we send the fixed tissue to carers? Is there any benefit in terms of identifying percentage of expression?
It's a good question. Yeah, the standard of care in all of these FDA-approved tests for PD-L1 expression is using fixed tissue. And so that's what all of the data is based on, is using the fixed, FFPE tissue. I'm not sure if using fresh tissue would change that, but all of the data and the clinical trials that we used is using the standard of care fixed tissue.
And on the clinical trial, where is FB4 stand now?
I'm sorry, can you repeat that?
On all the clinical trials you mentioned, how do you select FB4 in the whole list of trials?
Oh, FB4. Yeah, so FB4 is a locally grown USC drug. It was originally developed to target angiogenesis, and we've been using that in combination with a checkpoint inhibitor. And when that study was originally written, it was before this study that I presented, and so we weren't selecting based on PD-L1 expression. And weren't selecting based on HPV status either. We're almost to the end of that study, and we've seen most of the benefit has been in HPV negative patients. So we've been trying to select HPV negative patients for that study. Once we finish accruing, then we'll do a full analysis and see. But hopefully we'll move forward with that drug combination also.
Great, thanks.